So we're going to have a second example and a trial that was using interim analysis. But we're going to, instead of me just presenting you the results, I want to take a different approach to this. So the way we're going to do this is for you to get the experience of being in a data and safety monitoring board. So what's going to happen is the following. I am going to pretend that you are the data and safety monitoring board of a study. And I'm going to pretend that I am the unblinded statistician reporting to you as the members of the board. The way this will go is that, like it happens in real board meetings in the closed session, the reporting statistician has prepared a report, has handed a report over to you, may or may not present the report to you. You review the report, and you are going to be discussing amongst yourselves what do you think should be your recommendation for the study. You may have some questions for me as the unblinded statistician. And I, as every other human being, am lazy. I am not going to give you information unless you ask for it. If you don't ask for it, that's your problem. So you feel free to ask me questions. I will answer questions to the best of my ability. And I will, once you've stopped asking questions and you have no more questions as a group, it's then your opportunity to discuss it amongst yourselves, and you have to come out with a recommendation. Now, you are a very large group, so we're not going to expect consensus. I don't also want to expect a majority vote on it. So what we'll do is I will ask your show of hands that you are wanting the study to stop, or you're going to want to recommend the study to continue. And as is real, every board member votes. There is no abstaining. And then, unlike what really happens, I will be now asking, not necessarily randomly, but ask one of the persons or two of the people that said they want to stop the study to say why they want to stop the study. And I will ask one or two of the people that said to continue the study, why you want to continue the study. And so be prepared that you don't raise your hand to stop the study because others are raising their hand. You need to know the argument. Don't raise your hand to continue because you are, everybody else is doing it. Yes?
Can we divide them into 3 or 4 groups? Even more easier. Maybe as a sitting there, not to go to that or that. So that as a team, they discuss, they can ask any question they want to ask, and they can conclude each one of them can say, okay, based on this is what I'm thinking as a team.
As
they
a
can
team.
play the role play, and they can, within that small group, the one can act as DS and the chair, and others can be the members, and they can discuss whatever they want.
So you have 3 DS&Bs?
Yeah, that's what I'm thinking. It's easier because it's large.
Because it's a large group.
Look at that. There's already 5 people.
All right, so you can be one team and discuss things and come up with questions. You guys maybe get closer. Some people come over here and sit over here and have 2 teams over here, just so that you can, the discussions amongst yourselves can be more efficient.
So this would be team 2 and then
team 3 over there. Yeah. The dental team over there can be the team. Okay.
It's easier.
All right. So
we have 6 here. We have 3, 6, 7, 8. Maybe one can go here, one can go here. Okay.
okay. So I'll start like one would start a closed session, and I'll say, "Oh, welcome everybody to this session. Thanks for your long travel and so forth to come over here. We welcome your input. I'm going to be presenting to you the study as it is now. This is the closed session of this study and not the open session, so there's no investigators here. You are in the closed session. The only person that is reporting information is me as the unblinded reporting statistician. I will have asked each and every one of you to sign a piece of paper that your conflicts of interest don't exist for the study. Every time we have a meeting, you sign again. So I will have done that. And I recognize that you are have other lives. You don't remember possibly what is going on with the study. So let me give you first a brief overview of the study that you are monitoring. So the study is called Systolic Hypertension in the Elderly Program. This is a randomized, placebo-controlled, two-arm study, double-masked or double-blinded. There's close to 4,400 subjects, over 60. Now I don't like the term elderly, but that's okay. That's what they were using back then. With isolated systolic hypertension. What does isolated systolic hypertension mean? It means that your systolic blood pressure is high, but your diastolic blood pressure is not necessarily. So it's isolated, as we'll call it. This is a study that was started in 1985. It's scheduled to end in January of 1991. The main research question in this trial is to examine the efficacy of hypertension medication to prevent strokes and other cardiovascular disease. The primary outcome is strokes. Okay? Other cardiovascular diseases are secondary outcomes. And so this meeting is taking place today. And a little bit about the structure. This is a multi-center study done in the United States. You are the expert members of the Data and Safety Monitoring Committee. You are external to the investigators. Amongst you, there are clinicians that are hopefully cardiologists, neurologists, neuroradiologists. There's statisticians, biostatisticians, and we may not have a medical ethics person here, but we assume all of you have ethics in considerations. Now, the study has its primary outcome stroke. Strokes are easy to detect if they are strong strokes. They're not so easy to detect if they are mild strokes. And so what we have is if somebody has a suspicion they're being in the study and they suspect that they had a stroke, they are instructed to go to their physicians, and then maybe the study physician. And at some point, everybody that has a suspected stroke has a CT scan or an MRI, and a funded neurologist of the study reviews that and writes a report. A funded neuroradiologist of the study writes a report, and we get your medical history and your chart if you were hospitalized from wherever you are. This is a well-funded study to be able to get all of this information. Why are we getting this information? Because this is the primary outcome. We want to measure the primary outcome correctly. We want to discard those that are not strokes, and we want to include all the strokes in it. So we have an event adjudication committee. This committee is made up by clinical experts who follow exactly the same protocol that the neurologist does, the same protocol that the neuroradiologist does, and reviews the CT scan, the medical records, all the relevant information, and decides, yes, this is a stroke, or no, this is not a stroke. It's a little bit of an involved process, but we feel that it is, the study feels that this is the most important thing, so it ought to be measured well. Okay? So now we are at our DSMB meeting. And let me show you, I've shown you all the, you've seen things in the open report, but now we are in the closed session and I'm showing you by arm, mainly the outcomes. But if you have other questions, you feel free to ask. What are the outcomes? Yes.
Can you tell us what meeting is that? Is it the first meeting or second meeting?
Okay. I will remind you and give you a little context. This is about your fourth or fifth meeting. We are about 7 to 8 months away from the end of the study. Okay. So this is in July of 1990. We have we have 85 definitive strokes in the active intervention. We have 119 definitive strokes in the placebo arm. So the proportion in the active is 3.6. The proportion in the placebo is 5.0. This was not calculated in hazard ratios. We're just giving you the relative risk or the rate ratio, but it should be close enough to the hazard ratio. Follow-up times are very similar among them. It is a long study, so maybe there is a difference, but we're using as metric the relative risk. The relative risk is 1.4 at this time. What does that mean? It means that you can interpret that as 40% higher risk of the outcome of strokes in the placebo arm than in the active arm. We have other data in this outcome table. We have all reported strokes. There are reported strokes that are still in the process of being adjudicated. So there's 93 reported strokes, and some of them are still being adjudicated. There's 131 in the placebo arm. But if we look at that, there's 101.41, so the same as in the adjudicated ones. Deaths are occurring. This is older people, and they're dying, but their dying is not differential between the arms. The relative risk is 1.09. There's slightly more deaths in the placebo than in the active, but this is a secondary outcome. The primary outcome is strokes. If we look at some strokes lead to death, some of them not. We have 78 non-fatal strokes. So we have 7 fatal strokes in the active arm. We have 111 non-fatal strokes in placebo, and so that's 8 fatal ones in the placebo. So 8 and 7 fatal strokes are not really different between them. For other secondary outcomes, I'm just giving you the numbers. You can easily calculate the percents, but you can see that there is more MIs occurring in the placebo. There's more transient ischemic attacks. There's more left ventricular dysfunction. This is what is my report. What would you like to know? Do you have any questions for me? You have seen this before, so you need to not be participating in any of the discussions. Don't ask me why it's not given. Ask me, can you give me the confidence in it? So,
Can you give me the confidence interval for the?
yeah, so I can give you the confidence interval for the relative risk of 1.4. It does not include 1. I had not printed it, but I can print it for you if you would like. But it does not include 1. The 95% confidence.
Whether it should be asked only the statistical point of view or any question can be asked only.
You can ask me any questions.
Then who is measured? By what machine it is measured? How it is measured? In this multi-subject study, the measurements are all standard
Yes.
These are all the things definitely going to.
Yeah, so I can reassure you that this protocol has standardized the intervention in the active arm. They've standardized the intervention in the placebo arm. They have standardized procedures. This multi-center study, we have trained and certified the staff and everyone's to follow the procedure. We have also kept tight control on the people doing the data collection. And I can assure you that the data is trustable.
No, my one question is it qualified nurses or medical person is
Yes.
better?
Yeah.
What is the ethics on as a study staff without seeing the results? When the proposal submitted, what is the ethics for the staff? Suppose the treatment assumed to be effective. How we are going to compensate or what is the justification for placebo? Mostly it is assumed to be the effective.
Yeah.
Trial.
So it was justified to do placebo. All ethical review boards agreed that this was an ethical study to be done. The funding agency agreed that this was an ethical study to be done because the standard of care for people that had isolated systolic hypertension and not diastolic blood pressure high was to not do anything. So the placebo is completely ethically justified.
Cut-off value for the hypertension given in the protocol, how much
Yes, it's in the protocol. I can email it to you next time, but now in 1985, we don't have emails. So it didn't exist.
Just to remind a few things. He is an unblinded statistician. He's responding as an unblinded statistician. Whatever you ask, he will be referring to a protocol.
Okay. Can you, in the next meeting, present the chi-square between these two arms? Because I have seen, of course, you know,
I'm happy to do so. I will do it for the next meeting.
from my side, okay.
You want to look at the
Yes, the serious and
serious adverse effects? Okay, hold on a second.
And the idea is you should talk among the DSMB members to conclude what is it you're going to do with this. It's not asking questions is right, but at the end of the day, Shrikant is going. I mean, the idea behind your decision as a member of this five people committee.
So you, committee member, you asked me about the adverse effects. The adverse event risks are very few. CVD risks are low because the incidence is small. Deaths are not significantly different. And the only difference that we're seeing is in the primary and secondary outcomes. But adverse events, there's no safety signal that we're worried about. Thanks for your question. Yes.
I was with the NCA chapter and
If you want to see the statistical analysis plan that was made in the charter, it said that you were going to be monitoring this with the O'Brien-Fleming boundaries. Anything else? I don't have the KM plot in my report right now, but I'm happy to send it to you after the meeting. Yeah. He's asking a hazard ratio and looking at that, but this is.
Be careful what you're asking for. As a member, the primary analysis here is related.
So the outcome here is based on a relative risk, not time to risk. Yeah, you can ask. That's why I said I can do it for next time.
But probably your response is not that you can give. You cannot give that.
No, but we have collected time to event, so maybe in the next time I'll be able to send it for you. But I will remind you that the primary outcome was whether it occurred or not. It was not a time to event study.
That's what I'm saying.
Yeah.
That's right.
No, it's not a time to event. Okay. Yes.
interim analysis happened? What happened, like, what were the results of that?
Oh, the interim analysis. Okay. Good question. I'll show you. Okay, so I will remind you that in your charter, it said that you were going to be using the O'Brien-Fleming boundaries to monitor the study. At this meeting, we are at 0.7 of information time, and you have just crossed the boundary. Hmm?
2.89.
Hmm?
Z value is 2.8, like,
The Z value is 2.3 something, fairly large.
okay, even 2.3 is also safe.
Notice that I don't give my opinion because I'm the unblinded statistician. I have absolutely no opinion.
For this, I will not take two things. Only 1 point.
So other committee members are listening to what one committee member is saying. You are discussing amongst yourselves whether you agree with what one committee member is saying or you want to say something different.
Again. When you represent the committee member.
Have you discussed it with your committee?
My opinion is, I led to other committee members that as it is a closed meeting, I expressed that I don't think that just 1 point lying around the 2.5. I don't think it's very serious. So the study should continue. We have to decide only the next meeting.
Yeah, you can discuss.
Yes.
I'm quiet.
For definite strokes, like, these are consistent pattern, and then also for all strokes.
So let me explain the chart for you. Definite strokes, which is the primary study outcome, adjudicated by committee, is the little yellow triangle. In the previous meetings, it had gone up, came down, went up, went up, went up. The little blue marking is reported strokes. And reported strokes had gone up, came down, gone up, came down. Now it's gone up. Deaths is the little purple star, and deaths were high, bad, and then has been coming down here, and it's not bad. So you understand the graph in the report.
As presenting statistician, can you give the next meeting the association of covariates on definite stroke and all strokes and death, how it is controlled that other covariates if it is taken? At least the board is so much interested to see this.
I'm happy to do that at the next meeting, but I will remind you that this is a large study and their covariates are very likely to be non-informative because they're balanced by randomization of over 4,400 people.
Because board is suspicious, the study is more than 60 years, because 60 years includes even 90 years, 100 years. How the death can be happened, that is so much interested by the board. That is the reason we are.
He said that he's worried about the deaths happening. He said, yeah, people are dying. They're older people, they die. But the death rate or the proportion of deaths is not different, meaningfully different between the arms.
The board will do the list of data.
Yeah, you will give us the variables. I will prepare it for the next meeting.
At least we expect age-wise
Yeah.
distribution on both the arms, how the death happen.
Hmm.
Just a quick question. You will also have non-fatal stroke and MI. Okay, that's right. Do they follow similar?
Um, I don't have the pattern of them on the plot right now, but the other secondary outcomes are much higher in the placebo than in the active. So they are consistent with the result of the primary outcome. Yeah, of course. Why the deaths are similar? Hmm?
Difference between active and placebo looks like significantly different between two groups.
Yep.
But the deaths reported are similar. There's no statistically no difference.
Right. So,
If
so
the
just,
randomization should be good, suppose it is randomized in very well controlled manner. So we are not expecting deaths to be similar between two groups.
whoa. No, this is, okay. There's people are dying from stroke. There's only 8 strokes, or 7, sorry, 7 fatal strokes here, 8 fatal strokes here. These are people dying of old age, of cancer, of all sorts of other things, all cause mortality.
Randomization is only on the first line that we see in the top. 2, 3, 6, 5, 2, 3, 7, 1. There should be a balance.
Okay.
So don't expect any balance in the outcome. Then you don't need to run it.
Yeah.
It's an outcome.
Outcome.
But in the baseline, yes.
Yes.
It will be a balance. That is.
What about the subgroup?
Subgroups, which subgroups? What subgroups are you interested in?
I don't know what subgroups are.
But again, if it's well randomized,
No, she's looking at the effect in different subgroups. Is the effect of the intervention the same, consistent in men as in women? I will be happy to do that in the pre-specified subgroups that are in the protocol.
So, as the outside board member, finally, please tell us what really we have missed.
No,
Finally.
I'm not
No,
gonna tell
not
you.
as a
no,
board.
after the session.
You have to, after the session, I will tell you. Does anybody have any other questions?
I want to understand what is your concern about that, even if it has crossed the line, I want to understand what might be the concern. As to why did I stop at this point?
Only one case, one is that 1 point, it's just plus 2.8. The cutoff value is 1.96. It goes near to the 2. So it is well accepted. So we have to continue it. Then only we can see the next trial what is better. Some more cases are going out, are coming below the 1.96. That's the look. Then only we can decide. That's only one case. There is the interim report. We cannot take the full decision.
Do we have confidence intervals for the Z values?
For the confidence intervals, yes, they're pretty tight.
So they're not crossing
They are touching and a little bit crossing that.
the confidence.
Even though the confidence interval must be lying between +3 to -3.
Yeah, so this is, you have 2 point, what was it? It's 2.3. The confidence interval would be for this, we already have this amount of information. So the confidence interval here was probably like this. Here, it's like this. Here, it's like this. Here, it's like this. Here, it's like this. And here, it's like this. So yes, there's a bottom part, maybe below there, but it's pretty tight. And the bottom one is still way above 2.
When is the next session?
You haven't scheduled it yet.
You see this time gap between the yellow points, or can you make it shorter? Space above that line. No, no, I mean, yeah, earlier interim analysis. How long my question, my
See,
concern is how long?
as what I understand from their demonstration, this board meeting is consistent in a 3-month interval or 6-month interval, because they are not the part of the, only they are getting travel and some honorarium, and they are also having their full-time job. As you are thinking, they cannot come once in a week. So the time is fixed. This meeting over means they will go for the next interval. What it is fixed, there only we can see. We cannot ask just after 1 week. That board cannot assemble for once in a week, once in a, what it is defined in the beginning of the meeting, that mostly board will decide. We will, for this study, we will assemble once in 3 months. They will be.
No, but
totally
you can request it. You can always request it. They may not do it, but you can always request it. So I hear that you would like to have another meeting, and, okay,
It involves cost on the project.
As a moderator, I'd like to traditionally say, sure, you want to.
whatever you want to have, you can have it. Right.
Yes, we can request. You can also request for a weekly. We need to meet. You can say, as chair, please send me the weekly report. Meet and see if there's any important significant difference. You can meet for a week. You could do that. And now, the last one is question, and we need to make a decision. What we're going to do, what is the result from this meeting?
May I have a protocol analysis results?
You would like to have a protocol analysis. That's a good question. I have not done that yet. I'll have to do that in the next analysis. But you're worried about people that are, the protocol is to take this pill. So I can tell you a little bit about the adherence to the pill, antihypertensive pill. The adherence is in the active arm pretty high. It's still at 90%. In the placebo arm, it's been going down, because when you have systolic hypertension, you feel the blood pressure. And if this placebo is not doing anything, you know that you're still feeling as bad as you feel before. So what do? They give you the study medication, you say thank you very much, and you throw it away. You may actually go and get the medication if it's available. You may get it. But I will remind you that the study is under intention to treat. It doesn't matter what people do. Any further questions? Okay, so we come now to the time when every DSMB board member needs to make a recommendation. And the recommendation is one of two. You either continue the study or you stop the study. Now, I'm going to remind you that I will choose, possibly not at random, somebody that says no to explain why no, and somebody that says yes, why yes. Okay? So everybody needs to be, first of all, comfortable with what they're going to recommend, because they may have to speak. And everybody must vote. Everybody in this section, except Vignesh, has to vote. And so I will ask, which one does the board would like to continue the study? And I want the hands raised high, so I see them. 2 to continue, 1, 2, 3, 4, 5. 5 to continue. Yeah.
Continue with the intention to stop, because I'm going to leave this in like 6 months or.
Yeah,
3
okay.
months period or 90 days period or 60 days period. Like, oh, I'm seeing this, I'm going to see the plan. I would recommend to stop if I see the same plan.
You see this?
That means holding. That means holding. For time being holding.
That means continue for the time being until I look at it again.
PI, you say you continue, but in the
Okay.
discussion, you say I'm continuing, or unlike some students should know, I'm going to continue, but we are going to visit in 3 months to make a final decision because we need to see the same trend or not. That
But you
would
will not
be-
tell that to the PI.
Not to the PI, to the unblind dissatisfaction point, right?
So that's, with that explanation, let's take the vote again. How many of you would like to have the study continue and revisit things? Shortly, quickly, etc.
No, I don't want shortly, don't want.
You don't want to continue.
No, I want to continue.
Okay,
but
then.
I don't want a short period.
Oh,
Regular meeting.
regular period. One regular period.
Regular meeting.
Okay, for short period, continuing.
Yes.
Only one of you? Come on, hands high. So I see them. No little
Would like
like
to
this.
Continue and revisit in the short period, that was the question.
Nobody wants to stop? You did not raise your hand. Do you want to stop the study? Oh, you were there last time. Okay, all right. So you two are not voting. You want to stop the study? You didn't raise your hand. Everybody votes for continuing
No, no, Sheena.
and revisit.
That's three-
Yeah,
three,
yeah, yeah.
So let's vote for people who like to continue and revisit in a short time.
I think that was everybody. That was everybody except.
1, 2, 3, 4.
No, I'm not.
You want to stop or continue? Continue? Okay, you have a comment? There could be a lot of things. So did you hear what Dr. Jayasilan said? The event rates are small. You may not be able to, in 1 week or in 1 month, get sufficient more events to happen. But that's another bit of information that you're told. But you have to now judge how short a time, for example.
But yes, sir, we can suggest to complete all those pending records.
Yep.
And confirm them at least.
In a way that doesn't unblind the study team. Okay. All right, so let's go back and vote. Everybody wants to continue in some fashion, or is there anybody that wants to stop the study now? Think about it. Suppose your mother is an elderly person with systolic hypertension, and she is in the placebo arm, or she would be in the placebo arm. Would you want your mother to have that 40% higher risk of a stroke because you're continuing this? You have to think not just from a statistical standpoint, you have to take it personally. Board members have to sort of identify with the patients that have this. The patients in the study and the patients that are outside the study. You have your mother outside, she's not in the study. You are denying her this drug. She has systolic hypertension. Or, I don't know, 2 months, 3 months, maybe your mother will die from this. Revisit the graph.
My reading is that as the yellow dots are going on increasing, as the data gets accumulated, the evidence is becoming stronger and stronger. Therefore, we never had a history of reversing it. So therefore, even if you do one more interim, it is going to show you better data. So therefore, I will not go for another interim.
In the reported strokes, so the blues, the reported strokes go up and down, go up and down, now they're up. Oh, at the beginning you have a lot of noise here. Dr. Jayasilan is saying that once it's stabilized with enough information, he sees it going up.
But the deaths are not showing whether from which arm. It shows the total death, not the which arm.
No, this is the Z value for death. So this is the test statistic for death.
So the confidence interval is still touching the line. It's not yet crossed the theoretic. I mean, of that, the last.
But the cut point is not based on
the
confidence interval. It's based on the point estimate. So all of you are willing to have your mother potentially have a stroke and not know the results of this information. Yeah, now I'm talking. Yeah. I would not say something like that in the meeting. I would be quiet.
But why I am convinced that you can observe in the graph what happens that those yellow line increases, that is only 1 point goes there. That is approximately you can see at the point, let us say 7 to 8 that. Then 7.5 to 8, no event. 8 to 9, no event. 9 to 1, there is no event. Yellow line, yellow dot observed.
No. We haven't got that.
Those yellow ones are the meetings that happen, the DSMB meetings.
Yeah. So
It's not the meeting results.
yeah, so this is the first meeting that you had was here, and it was early on in the study. You're here. You are scheduled to get the amount of information at the end of the study will be 100%. And you'll have 1 or 2 more meetings there. But at this meeting, we're here.
No, my only worry is that what is the difference between the last meeting and this meeting? How much it is? Only one. One is not, sorry, one. It is.
You went from a Z of 2.2 to a Z of 2.4.
Little, Z value little increase.
That's a big increase. And then the previous one, it increased the math a lot.
I am not convinced for stopping that because the trial did not give me a very good evidence for placebo side or the treatment side. It did not give me a bigger evidence. So the benefit of the treatment will be totally stopped if we are taking a hasty decision unless we see one more round of treatment.
Just to clarify that p-value for that one, if you are very interested about the p-value, it should be 0.008
or something.
Yes. 0.1.
Unadjusted for the income.
Unadjusted and adjusted. It's sort of point of this, even rates are quite low. Would it make, would it be want to stop the study at this point in time, because even one or two events in the placebo arm could bring down your Z value next time. So if this study had given rates are much higher, let's say 20% and something like that, I would be much more worried about the ethics of stopping. But I don't know what the absolute risk difference.
So
is.
as an unblinded statistician, I could tell you that, yes, it's possible that a few events could make it change. I don't know, I cannot answer the question of whether it's okay or not. That's a judgment, and I don't give judgments.
Definite scopes are 100% confirmed.
Confirmed by the adjudication committee.
How many events that is confirmed is, sorry, reported is not confirmed.
So, no, there's more. So they have 8 in one arm and 12 in the other. So there's 20 that are in process.
All of those 20, they go in the active arm.
No, 20, let's just clarify that. If there is 20 reported events over there in placebo, it will stay there. Either they will be confirmed as an event or it will be refuted as no event. That means this 20 can add there to make it 139, or all 20 can be refuted.
No.
And to
It's
stay
by arm. So there's 12 here. So these 12 can go here
12
or
can go
not.
there, or 12 can.
8 can go here or not. So you could say those 8 don't go and these 12 go, or you can say these 8 go and these 12 don't go. Those are the worst case, best case scenario.
So if we do the worst case, how much above that line, so between the blue and that yellow dot, because the blue dot is very convincing. The blue dot and the yellow dot, where would I?
So that's a good question. You are just as capable as doing proportions as I am at this moment.
Yeah.
You may have a calculator with you, you could do it. But if you take 85 in the active and add 8 to it, so you have 93 there, and you have 119 there, you can calculate how much is 93. Oh, it's 3.9. We know. So 3.9 to 5 becomes what is the relative risk? No, 5 divided by 3.9. Somebody has the cal. 5.0 divided by 3.9. 1.3 something. 1.28.
So instead of 1.4, the worst can happen is 1.28. With not including one of the conference.
Right. So you would be at that point, let's say, below the cut point. In the worst case scenario.
Like if you start the trial today, let's say you need to close the study, it will take 2 months to close. Now you need to complete all the application. Still get a significant response. Your question.
Yes.
And he's saying, and by the statistician is saying it's not going to be, it is going to be significant. It was worse than. So now the decision is, you continue or you stop. Yeah. That's a great question. That's what I'm saying. That's exactly what we do.
No, I said that if you do that, 1.28 will be slightly below the.
They know the stopping rule is one thing. What she's asking is, let's say we recommend as per the stopping rule, we cross the boundary and stopping the study. What is the risk of stopping the study?
Oh, okay.
Risk is you're not going to get any significance if all the adjudication completes.
Right. But you'll still get a Z value or 1.28, which is highly clinically meaningful and significant.
That's the point. Because we need to be protecting the trial too, right?
Right.
Stop the trial and then it becomes non-significant, then it becomes even more. You all understand what she asked?
Yeah, so what she asked is, if you look at this, these are the primary outcomes, it's because they have been adjudicated and confirmed by the committee. But there are, in addition, in the active arm, there's 8 more, so there's 93 here. And in the placebo arm, there's 12 more that have been reported, but not yet confirmed. Why are they not yet confirmed? Because they're in the process of being confirmed and adjudicated. Remember, I mentioned to you, there is a very cumbersome process of reviewing MRIs and CT scans and reports and whatever. That takes time. And so if in the worst case scenario, the active had all of these happening here, so all of these are confirmed, so we get 93 here, but none of these 12 that are extra here get confirmed, we stay with 119. And in that case, now I'm stuck because I'll have 119 here and I'll have at the end 93 here. So when I do the relative risk, it's 1.28. If I convert it to the Z and look at the boundary, I'm actually slightly below the boundary because I just crossed it. But that 1.28 will be statistically significant. And so I will get a significant result after stopping the study, even if when I finally do the adjudication. And that's in the worst case scenario. In the best case scenario, what do I have? I have none of these going here, so I have 3.6. I have all of these extra 12 going here, so I have 131. So now it's 5.5 divided by 3.6, and I'll get a much higher relative risk. So she was concerned about the adjudication process having you call it the unadjudicated events potentially affecting the result of the study. Yes.
Worst case scenario that despite the worst case scenario, the point was above your line. That means we have been all right. But what would happen if we followed up these patients and the numbers completely changed to that?
The worst case, right?
Yeah, but that is only for those who are not. There are more patients still followed at this time to follow. By that same
That's
logic.
more events coming in.
Yeah, more events. Because they're on the fence with that number being so close to the line, we're on the fence and they're hoping that what's already occurred right now. I mean, the best case scenario is that then it will push it up. And then, so can we just wait till those are adjudicated?
You are free to recommend whatever you would like to recommend.
You can do that. Now, how will you do that without unblinding the PR?
So the worst case scenario doesn't really.
No, that's not. He's an unbiased statistician. So you want all the zeros to be adjudicated, right?
Yeah.
You tell that. How will you tell that to the PR?
For another.
No, so you're in your, suppose in this situation, what you would say is, in your letter, after this meeting is over, you have to write a letter to the PI saying our recommendation, we carefully examine everything, and we recommend that the study, as you say, suppose the group decides to continue, we also recommend that you adjudicate faster. And you're saying, why are you asking this? We're supposed to be always adjudicating faster. Why are you asking this? Something must be going on.
Yeah, by that time, let's say you are accumulating more events. Not all events would be adjudicated when it comes to a deal. Ongoing part. That's for the question. What is the worst case scenario?
Yes,
What
but the worst case scenario is has not given us changed our situation that we are still on the fence. On the line.
It would change it. You would be below the line in the worst case scenario.
It doesn't
lines are also.
Does it change our decision?
I will tell you something, that line that you're talking about is a stopping rule. Stopping rule does not apply when you're doing the best case or worst case scenario. You don't look at the line there. According to the line, I'm going to stop it. But now I'm looking at the worst case scenario. Is it the trial going to be significant or not is what I need to look at. I should not looking at the open line or anything. That boundary information is more on the official. That's only when you're stopping it.
Now you've say, yeah, so now that you've stopped the trial, you do your analysis, you're going to be doing it at the 5% level of significance. And you'll have a 1.28 relative risk. The Z value for that may be whatever it is.
Including one,
It will be,
confidence includes one. Relative risk.
no, it will not. It will be, it will not. It will be higher. It will be significant.
We get 7 months more to finish the trial.
Yes.
You are just 7 more months. You're just saying, you have just 7 more months.
7 months more.
You can say, oh, just 7 more months, let's continue. And we stop.
You can say we-
One
say
more
we can-
question as a board statistician. Of course, it is not so important. Why equally not distributed? Placebo arm subjects are not equally distributed. Little higher side on the placebo.
4 people, 5 people, you call that, you know,
Why it so happened?
it says 6
5,
people.
2, 3, 7, 1. Little higher that side.
It's not perfect because one site, I mean, we're doing permuted block design. One site had a block of 6 or block of 8, and they only got
Okay,
3
block-
people.
block
It's
wise.
just random.
Okay.
It is not meaningful difference there.
I mean, it's good, it's in the right direction, but for there to be so much of a difference between the activities is something that is very much, obviously it's related to, this is also quite a difference. It's just some measurement.
Yeah, if you're worried about that difference, I will talk to the physicians who may counsel me. I'm not really knowledgeable about left ventricular dysfunction to be able to answer a clinical question.
And it has shown this pattern over the.
We can go to the previous reports and there's more of these.
So, that's why I'm saying it.
You are talking to your other board members.
Yeah, I think I. So,
Reason. Why?
the safety, because we mentioned that the adverse
Listen,
events are.
there are 2 issues here. Number 1, when we look at the debt, it is 0.09, and it shows that the relative risk is more on the placebo. That means placebo side. That means the hidden benefit of the treatment group is hidden. We are looking at the relative risk of the person who did not receive the treatment in terms of the relative risk, in terms of this death, both, of course. But we are not seeing what is the benefit really the treatment group got. We are not thinking on the treatment group. We are talking on the placebo group. What is the risk for the placebo group? As they are not taking the treatment, how much the risk is we are quantifying. That is, even looking at this death, 0.09 is more percentage, and 100% is going to include the confidence interval 1, and it will be very wide confidence interval, unstable. The benefit is we are not looking at what treatment is giving, we are not looking at it. Because relative risk says only about the placebo, why it is not giving.
But just to clarify that, as Shrikant mentioned, death is not significant. It's 1.09, but it includes 1. There is no significant difference between treatment and placebo on death as an outcome.
And I will also remind you that death is not the primary outcome.
Yes.
I'll also remind you that it is consistent with the results of the primary outcome. There's more deaths in the placebo than in the active. The placebo is doing worse than the active on everything. It's all deaths.
It's an adverse event.
That is like,
Yeah, it's significant.
My comment, specific comment. Actually, placebo group, they are not taking the medicine properly. Only 60 some percentage are coming. But treatment group, they are taking more than 80, 89, 90 percentage are taking. So, but still there is more chances for getting stroke in treatment group.
But I will remind you that the placebo not taking the medication doesn't mean anything. If they took the medication, it's placebo, it doesn't do anything. If they don't take it, it's placebo again.
Not taking or
Yeah.
that's not method, but treatment group, it's more than 80%, means 89 is coming. 89, more than 90%, they're taking properly the medicine, but still we can't tell treatment group is more effective. Means
Yeah, we can. We can.
Not
This is the treatment
No,
group.
no, just to clarify, here 1.40 means it is working. Don't think of the hazard ratio where it's less than 1.
We are taking placebo over active instead of active over
So
placebo.
this is placebo versus active. They are comparing the
effective, but same way placebo, we can't tell that it's very bad or good. That we can't tell.
Our idea is not to talk about this placebo. To say whether treatment is better than placebo.
Yeah, I'm just telling treatment group is showing good results, but not, we can't compare now. Means only 7 months are there. So within that 7 months, I'm thinking nothing will happen worse, so we can continue.
Oh, nothing worse.
Means treatment group itself now it's showing some good results, but in placebo, means we can't tell that compared to treatment group, in placebo group more deaths are happening or more strokes are happening. We can't tell that. Almost we can see that we are having more strokes and more deaths. More of every we have 85 and 119.
what she is telling you or not, nothing big sea change is going to happen. If it happens, 5%, 10% happen, like that.
At the end of the study, we can conclude that's a big difference, I think. Like to get this much of a difference.
So would you put people at risk? So the question, ethical question that comes into, I'm going to say, but the ethical question is, would you put the people at risk for another 6 months? Or would you not? It's a question that you need to think about. We are running trial on people. Would you put me at risk at placebo for another 6 months or not?
So this is the almost end of the time we are conducting meeting. So initially the beginning means after some months or years, we had one meeting. So this is same question will be done on that time. So in that time we have decided we can continue. Then why we are thinking now we can stop?
Because we never cross the boundary.
Because we've crossed the boundary now.
This is the point where we are even talking about this to stop the trial because we cross the boundary. Let's say you don't cross the boundary. You're not going to even talk about it. I'm not even going to discuss about it. Because I need some evidence, statistical evidence to even talk about something. If you're talking about an efficacy point of view, not on the safety point of view. Safety is always there. If there is a problem, we stop it.
This is what is the this thing, DSMB number what?
This is number 7, 6.
7. Sorry, can you go to that first table? See, this is, I think, the 7th report it is showing us. If it is shown to me all the 7 values, so I will be very easily.
I am showing it to you.
That's there.
That's there. That's the 7.
Okay.
These are the previous ones.
But it is-
Number 1, 2, 3, 4, 5. This is number 6.
Sir, this is Z value. Z value.
Yeah.
This is. But what I am looking is the relative is how it changes.
No, well, then you can back calculate.
All this.
Hey, think of, take the next yellow one, okay? It's over there. It's about 2.
And what would be the relative risk? It would be around 1.15 or something.
But the relative Z is that a test statistics value. How I can go back to the relative risk? It's not so easy what you are telling. I cannot accept.
No. So the relative risk is as simple as looking at one proportion divided by another proportion.
Yeah.
If I actually, instead of dividing, I subtract one from the other, and I have a difference of two proportions, I can calculate the Z now. The numbers are there. It's very easy to calculate.
It's going to be significant.
That 50 yellow point, that also
Okay.
means it close the boundary.
What's that?
That 50 yellow point.
No,
that
no, the
also
boundary
means-
is the red line.
No, it's below. This is the boundary is here.
The red line is the stopping boundary, but we are talking about significance. So there's two concepts of significance. You can have a significant value, which is 1.1, and it can be a very tight margin, and it can be significant too.
If I
But then, sorry, one second. And then there is a boundary. We need a clear evidence that it is highly significant. That's what the boundary talks about.
If I am a board statistician, of course, I
You
will be
are.
having all the reports, not the statistician every time he will doing the whole report. I will be having in my office. Definitely, I will review those things, say that, and taking this, everything I will put conclusion, then only I will come to the conclusion. Just seeing only one point, this thing, this one thing.
I'm giving you the
I cannot
previous
do
points.
I'm giving you all the information is there.
Even then also, I will see the whole report
No, no.
also.
Right now, we cannot print you
Right.
everything, but I'm giving you all the information there.
But I am not, just this point, it is just about the line. It may come down also next visit.
Sure.
That is why I am not convinced to stop the trial. Number one is that, yes, very clearly, it is benefit. Which one? The treatment is benefit, but it is not significant, but
It is significant.
This is significant.
significant. Then we will see how much significant. So it may
It
still
is highly
increase.
significant.
Huh?
It is highly significant.
Significant. Relative risk wise, how much?
1.4 and the p-value is 0.005. I'm telling you, it's a highly significant result right now. That's what we are telling you.
1.4 can be significant. Relative risk.
Yeah, when you have 4,000,
40% increase.
Of course.
40%.
you have 4,000 people in the study.
That is why I want a real p-value.
I'm telling, no, you don't need a real data, real numbers, imaginary numbers.
If it is significant, yes, it can be close.
Okay.
Sir, if you go to the first table, please. This is just a question. With that data alone, say like with the 40% increased risk if you're not taking the drug, right? That's the inference of that, right?
Yes.
Yes.
If you're not taking the drug, you have a 40%.
No.
The
Comparing to the placebo, right?
Yeah.
So with that data alone, say for example, if you stop the trial now, we already understood there is a significant difference by taking the medication. It prevents stroke,
Yes.
right? So, and then we make it a practice. Why do you continue with the trial? That's can we make a decision only with that itself, right?
That's what you're trying to do. That's what I'm asking you to make your decision.
And that's
Okay.
what she was asking the next question, just to reiterate. That's the most important question is, here I'm stopping it, but there are some events not adjudicated. Just the concept of adjudication, maybe not all of you have experienced that.
Correct.
There is a reported event, there is an adjudicated event.
Correct.
What is that? You're saying
Kind of
you have a stroke.
certified.
Somebody can say, I have a stroke. But
But not
medical
certified.
Doctor need to confirm,
Confirm.
yes, it is a stroke. Or they can say, no, you said it wrong. It's not a stroke. I'm not going to categorize as stroke. And now there is no longer an event. So worst case, there are around 8 plus 13 events need to be adjudicated yet.
But even when we put the worst of the combination, we get 1.28 or 1.6. These are the extremes, right? So even if you come to 1.28, still it makes a statistical significant impact or effect, right? So with that, probably,
What's
When
that?
it comes to 1.28.
Yes.
With the
Oh,
Z
score will.
Z-score will drop down, but the
below
statistical, the
But-
signal, yeah.
there, but it's dropped below the stop.
That's
Correct,
fine. But
correct.
again, think about this.
Okay.
When you are stopping the trial discussion, you talk about the line. But the moment you talk about worst case scenario, best case scenario, you don't worry about the line
Line.
there.
Hmm.
You cross that point now.
Hmm.
Now you are saying about the results.
But my point is, if we did stop the trial, and theoretically, if we imagine that we had those results.
Yeah.
And they showed 1.28, the Z would not have crossed.
Of course, it
Oh,
won't come.
not
It won't
Correct,
cross.
correct.
So.
Then the discussion wouldn't have come.
Yeah,
Isn't
my
that
point, yeah, that's-
discussion of stopping may not
Oh,
arise?
yes.
If we had these reports.
You are
we would
absolutely
have
right.
never got to the point where
Absolutely
we're
right.
discussing stopping.
Absolutely
Therefore,
right. Absolutely
My
right.
opinion is that we should continue till we get a few more events. That's what I mean. Because
Okay.
if we had those reports and it had not crossed,
Hmm.
then we would not have had this discussion. So therefore, we don't have
That's-
enough information to conclude with my.
Sure. That's the right way to put it.
I just have a doubt. This is probably because, I mean, you've spent the whole morning explaining that stop line, and I just have a question regarding that. So, right now, when you were saying that though it is right on the stop line, if we stop the trial at this point, you're really going to get a very significant result. But if we go to the graph, and so my understanding of the stop line is that that stop line is way above what is statistically significant, what could be statistically significant at those time points. It's that the confidence interval is becoming tighter as you progress to the right. So by that logic, if we take I don't know if I'm totally getting this wrong, but if we take the yellow triangle at 0.5, between 0.5 and 0.6 information time, where there's been a huge jump from the previous Z value to that Z value. Yeah, that jump from the 0.45 to 0.55 time period.
For this period.
Yeah. What was our thought process at 0.55 to continue I mean, would we have of course, it's way below the stop line, but the stop line is set at a point higher than what is significant.
Right.
So at that point, would we have thought that would we have seen the p-value and said,
You would have seen. So,
and the confidence interval and said,
so
how
let's
did
say-
we move
Okay,
beyond
I'll
that? Because
explain.
that's a huge,
I'll explain. So very good question. So when you are early on in the study, you still have constructed this red line. That red line is based on the O'Brien-Fleming cut points, and it's there. It's based on information, the calculation of that line. That line is not changing every time you have a meeting. That line is there, that curve is there. So when you are at this meeting, the first meeting, you were here, way far away from what it would have been. When you're here, you're way far away from what it is. When you got to this, you're still very far away. Then when you got to meeting number 5, you were getting closer, but you're still pretty far away. Now at meeting 6, you've just crossed it. So that triggers the discussion. Now that just triggers the discussion, you are discussing whether you want to continue or stop. If you continue, that line continues to be there. At the next meeting, who knows? Maybe this may come down below at the next time. Or it goes up. Who knows? The future. Now, if you stop the study, the line is no longer valid piece of information. You stop the study, and let's say the adjudication goes the worst way. You get proportion relative risk of 1.28. The Z value turns out to be 2 point something. Here it would have, if it had stayed this high, those adjudications stayed here, it would have been fairly large. It would be 2.9, but now it's 2.4. And you do the 95% confidence interval, it doesn't include 1. You're going to be somewhere, even if it comes down like this, you're going to be here. Confidence interval is going to be there. Highly significant, what Kumar said. Right?
But at the previous meeting, would we have also considered the confidence interval? And
Yeah, you could have considered the confidence. Maybe this confidence interval was even crossing, the top part was crossing, but you were so far below here You did not even want to discuss stopping.
But would it have been significant?
Yeah,
Yes. So at that time, doesn't it trigger the question that are we subjecting, because our question here now is between completing the trial or subjecting more people to something that we're pretty sure is not the best treatment anymore. But that
That's a
shouldn't
good
be a
question.
question actually.
yeah, I see your point, yeah. So at this point,
Constructed the red line so that for the people, for us
Yeah.
who are running the trial, we don't waste resources. But if
Right.
we're looking at it ethically,
Yeah.
from the patient perspective or the person you're subjecting to the control arm.
yeah, but maybe the confidence interval here is not that tight. Maybe it's like this.
But
It-
still significant.
But 1.96 is here, and it would be not significant. 4,400. The event rate was to be about 4% or something like that, and you're about 4%.
Anyhow, apart from the statistician, the board clinicians can take the decision by arguing that what she says is correct.
So the board comes up with one recommendation for the whole board.
Yes, we
There's
are
not
discussing.
one from the statisticians and one from the
No,
clinicians,
we
it's
are
one.
discussing, and the clinician convinced me that, yes, it's more than enough, no need to move, then we can stop using it.
You as the board can recommend. Collectively, you come up with one recommendation, but I'm going to change the standard operating procedure of the board and allow each board member to vote on their own. We don't have to get to a consensus. So now, board members, raise your hand if you want to continue the study.
Last question.
Yeah.
Is this the interim analysis, the 75% interim analysis, or is just
So this is an interim analysis. It's not at 75%, it's at what, yeah, maybe at 75%.
let's assume that.
So just one, can you go back to the table, sir? Normally, can the board, this is again a question, can the only with the primary outcome? Do we, at any point of time, DSMB considers the other outcomes, or we don't consider at all?
And every time they consider everything,
Okay.
but this p-value stuff is usually only for the primary, but you can ask for p-values for everything. And you can look at all things.
Even those values play a role in decision making, right?
Everything plays a role in decision making, not just the
Primary outcome.
primary outcome, not only the efficacy part, but the safety part, the operational parts, everything is considered.
Thank you, sir.
I think we need to stop discussion and vote. Again, the meeting is only 1 hour. If the meeting goes on and on, then the coordinating center has to provide food to you. And they don't have the budget for that, so we have to stop. All right, raise your hand high if you want to stop the study now. Okay, I'm looking to see who has it to then ask questions. Okay, and those, I'm assuming that those that did not raise their hand want to continue the study. So I will ask you in the back middle, why do you want to continue the study? Explain to everybody. Okay, so
Already 5 years study completed. So the recent time only we are getting that value is
Okay.
more.
So now I'm going to speak not as the unblinded statistician.
Okay.
I'm going to say, so you want to continue the study. You don't think that these elderly people that are suffering strokes, one of them that could be your father or your mother, it has hypertension and is getting placebo, you are willing to risk their lives with a stroke, not
Sir,
their
if I'm
lives.
taking emotionally, I
Yes,
will not tell
you
no.
have to think emotion. This is what I'm trying to say. You, as a board member, have to put yourself in the patient's viewpoint. And the way to do that is to think emotion. So that's something to consider. Now, people that want to stop the study, you in the back, not way back, but second row. Yes, please tell us why you wanted to stop the study. Yeah. Better to continue, better to stop. You voted to continue. You wanted to continue or to stop?
Continue the
Okay, well,
trial.
then tell us why you wanted to continue.
Because it is 1.24. We're talking about it is highly significant. So although I do have in mind about the 40% higher risk,
You
still
are
at the
willing to-
benefit of
So the same as
40% is high. I do agree, but
so that you're willing to put these people at risk.
that's a sad.
Sad thing.
That's too bad.
That's too bad. Okay, so
I feel sad, but considering the cumulative effects, I know I shouldn't go statistically, and I should take decisions.
One is to get continuing means you want to get more information.
Yes.
And so to get more, don't
I'm
you think
sure
it's
that
convincing
that line
enough?
will come down the boundary.
Oh, that you're worried that more
Yeah,
information will make it come down.
Yes.
Aha, okay.
But as
The boundary doesn't come down.
no,
the
not the
significance.
boundary. Yeah. But I do agree. 1 week or 1 month's time is too less a time, and meantime more events will occur, which is really sad and bad.
All right, then stopping. Who said they wanted stopping? I already know why you want. I want to ask somebody else who said, why do you want to stop?
Now in 2 minds now. Yeah, I was a little bit concerned about the low event rates that I had mentioned earlier, whether that maybe few events in either arm could tip it either way. That was my only concern.
Well, so you see how easy it is to come to a decision or recommendation. It's extremely easy being on the board. Fantastically easy. Well, I can tell you what happened when the board decided. The board decided decided not to stop. The reason they decided not to stop, they had to wrestle in their minds with the ethics of having people that have high systolic blood pressure, that are having more strokes that are potentially creating hopeless quality of life for people. If they die, maybe they're better off than if they don't. They're not causing more deaths. So they were okay. We're not causing deaths by going on, but we're worried that we're causing strokes. But we wanted to be sure that they were worried more about this aspect, that the worst case, best case scenario may be what it is, but it's going up and down, it's gone up, and maybe it comes down a lot, and there's more events. So they said exactly what you said. Let's adjudicate faster. What is this problem with adjudication? Why is it taking so long? So they said in an indirect way, the study needs to come into a close. Why don't we do things more efficiently? And politely did not give a hint to do this. So the study, because they were concerned about exactly that we may end up being below the boundary. And even though we may be statistically significant, and somebody asked it, why did you stop it at such a low hazard ratio of 1.28 or 1.2? That may not change clinical practice. We wanted it to be, the trial is supposed to change clinical practice. You want it to be convincing enough to the medical people that this was something that will change. They've invested 4,400 people for 5 years. Millions invested. Let's be sure. So they did what you said, exactly suggested. Let's continue. Let's try to have relatively quick meeting soon. But then they say, oh, the event rate is low. It's the Sealand said. So can't do it in 1 month. No, 2 months. All of you are very problematic. You have your busy schedules. They could not get you to come back together relatively quickly. So now, what happened? Your next meeting came in December of 1990. 5 months instead of 2 months or 3 months. Look what you have done by letting this study continue. The relative risk now is 1.47. Look at how many more strokes you've caused in the placebo arm. The active arm is staying at now 3.8. It was 3.5, but that went up to 5.7. Now it's 1.47. You actually, you're going to have more deaths here, but it still has 1.09, so it's not that much different. But you had so many more non-fatal strokes. So you had only those 7 that you had before. You didn't have any more deaths here, but you had 1 more death here. Okay, but you had more heart attacks, you had more TIAs, you had more this. So by letting it go, how can you sleep at night having this go? Okay. So now we came to this meeting. What is your recommendation? You say continue. No? There's 1 more month to go.
No, regular, no.
He doesn't want to stop the study. You discuss amongst yourself. Yep.
Why did we say that it's not enough to change that? Because it's a highly significant difference at that point.
Because the relative risk was 1.2.
But we had a significant difference,
Because
which
people know that statistical significance is meaningless when you have 4,400. Everything is significant. You want the importance of the magnitude of the effect to be large. These people know that statistical significance is a meaningless property. It's just a crutch that people use when they don't want to say this is a meaningful effect or this is a not meaningful effect. Significance is not importance of the result. And so you may get statistical significance, but it's a not important result because the magnitude is 1.2 or 1.3 relative risk. If you wanted to change practice, you better get a big effect.
then why have a stop line? I mean,
Why have a stop line?
I mean, are we beyond that at this point?
I'll show you. You are. Put that line again.
Doesn't this mandate stopping? I mean,
Yeah, this mandate stop. Look at that. You are at almost 3. Yeah, if you had stopped earlier, you would have saved not lives, you would have saved strokes. You did not get any more deaths, but you would have saved so many strokes. Imagine your uncle got a stroke. Look at the all strokes. It jumped up from here. Instead of going down, you thought it was going to go down, it went up. But nobody knows the future. That's the beauty of this stuff. Nobody knows the future. And you have to see how difficult it is to ethically judge something, not knowing the future. So, questions? Yes.
It's gone from July to December. It's just probably 1 month left. Whatever decision you take.
I don't take any decisions.
it's-
Whatever recommendations you make, you're free to make.
I would say we can definitely stop the study now. Our only point of contention last time was whether those unadjudicated events would bring it down significantly. By the time it's reached here now, whether you've adjudicated or not, whatever happens in the last 1 month, it will definitely not change anything. The last time it was not necessarily like that. In the sense, suppose those events were adjudicated, we would not have the thing cross the stopping line.
Yeah, but this stopping line, no one will see. So the only
No, I
thing that's
agree.
probably improved is the optics of it.
No, but we can now tell the PIs, unblind them and tell them you can confidently stop. It will definitely benefit your patient or whatever. You can tell them to
But
stop.
that I feel we
You have
could've said the
you
last
have
time also.
Z value of 2.9 almost,
Nine,
right? So
yeah.
it is, and
No,
the
but-
hazard, I mean, the relative risk is 1.47. It's huge. It's unlikely that it's going to come down. If it came down, it would come down to 1.42 or something like that. And it will change clinical practice.
Last time, if we had said that, and on the off chance that they lost out on the significance, not I mean on the
Right, on
on
the
the
sig-
magnitude of the outcome, not on the significance. It was already significant last time,
Right.
but last time they would have lost out on the magnitude of the clinical outcome. Because as a physician, for us, it matters a lot on how much that difference is. If the difference was shown to be a lot less, the
But it's not a lot less, right? Earlier
no.
it was 40% and now it's 48%.
We're almost there.
No, I'm saying there last time, if those adjudicated events had come in and in the worst case scenario, it
Right.
would have shown a lot less difference by.
So, but that can happen now also, right? If you're expecting the worst case scenario in the last for it to bring down to 1.2, I would do the same worst case scenario in this case and for it to bring it down to 1.3.
You've got 8 more here,
Yeah.
and you've got 13 more here that are still in the adjudication process. Yeah, it'll come down some, but
So 1.26 versus 1.3.
all right,
Yeah,
we,
but-
in the interest of time, we will have one more question or 2 more questions. Go ahead.
I just wondered whether the cost or the side effect profile of the intervention had anything to do with whether we could have
Side
So-
effects?
of the intervention. So this is an intervention where we've given a pill, an antihypertensive drug. Unlike, say, a massively expensive or drug or a complicated surgery or something like that.
Right.
And we've not shown any side effects in the sense of something horrible happening because of the drug. So even if we didn't have a massive effect size, would it have precluded, even if clinicians didn't have a massive effect size, giving a drug that could potentially benefit a patient, it would have still changed clinical practice is what I feel. Would we really be chasing a number to change practice to give us some?
I can tell you the story of the poly pill. No, you're not going to change practice even though it works, because no pharma company wants to sell something that doesn't give them profit. So it's changing clinical practice is not.
So when you say something is statistically significant, aren't we saying that it is going to be better for the patient to get it?
Yes, but that doesn't mean that it changes practice.
But then on one side, we're saying that we don't want to, ethically, we shouldn't subject more patients to strokes. But and we know that it's working. We just need this number to convince pharma. I mean, that doesn't make sense
No,
to chase the larger
You need
effect size.
numbers to confirm your clinical colleagues to do this. They're not likely necessarily to do it because it's statistically significant.
I mean,
They're
that's what
more
I'm saying,
likely
that
to do
that
it
factor in the intervention that we're talking about. Say it was an intervention like giving something worth in an Indian scenario, say a 5,000 rupee tablet. Yes, then I would need a big effect size to say that. But in Alapril, which is so would that have been a factor that would have come into the DSMV's?
Yeah, I mean, they may have thought
discussion?
about it. I don't know. You're the DSMB. You're thinking. Yes, last question. and then you have to vote.
Just slightly a different question. At what point of time will you start thinking about the futility of the trial? Because at 20%, when you recruited 30%, 40%, there was no difference in your event rates. At what point in time when you start thinking, okay, we had the amazing results at 60% or when 0.6 or 0.7 time. And in the same graph, at what point, let's say at 0.5, would you start thinking about futility, or is it too early? Or when do you start deciding that regarding the futility of the trial?
Well, yeah, so usually futility is not.
Because by this time, we've almost randomized 2,000, maybe
We
2,000
randomized
patients.
everybody, right? So it's not, they're not still randomizing. They're randomized in the first year or so, or 2 years. So when you have information time at 0.5, that's when they start saying, oh, maybe we should start, if they have it in the protocol and in the charter, that they're going to be monitoring fertility. If they don't have a formal criterion for it. They're looking at it, but they're not formally, they're non-binding. They may look at it, as Dr. J. Seelan said, they will calculate conditional power, see if it's less than 20, 30%, and then maybe consider. This group did not consider futility. It was, and they did not plan for it. They only planned for stopping early for efficacy, not for futility.
At 0.5, should they have considered for futility in this trial?
I would not, because you're still, you are in the right direction, right? The Z value is positive, so you're going in the right direction. If it was a negative value or around here, I would be around here. I would be thinking maybe it's this, it's not working or it's working wrong. Yeah.
The 6 analysis, power analysis.
Yeah, they did a conditional power analysis. I'll show it to you. So in the meeting that you had in July, I had calculated the conditional power. Nobody asked for it, but I had done it anticipating that you may have asked for it, because as an unblinded statistician, if you ask me in the meeting, I don't have a way of doing it there. I prepare beforehand for the meeting. I think about what you are going to be asking me, and I prepare things that you may ask me. So anyway, what is the conditional power? For final strokes, we're at 63%. For all reported strokes, we're at 87%. Remember, the cut point for efficacy is usually 80, 85, 90. So you're there. You're not there yet for conditional power, but pretty close. So yes, we calculated conditional power. Yeah, for final stroke, our primary outcome is the definitive final strokes. This is the reported one. So we are not there for final strokes. And this is what they were concerned.
Yeah.
Over there.
Actually, earlier you have explained that they allowed this trial to continue on an explanation that this death is far better than stroke, or the disability due to stroke is more, some logic.
No, I said that
the reason
we are not causing harm by killing people more, but yes, we are causing harm by letting more strokes that could be disabling, could be that. But the reason the committee decided to go on was they felt uncomfortable that the trend is looking okay, but we could have a conditional power that's not yet there, even though they had not planned for that in their charter. They did not have it as this is how we're monitoring. You asked for this, so I prepared this in case you wanted to have this. The committee actually asked for that, and they had that, and they said, we are not yet there to stop the study early for that. All right, last question. We have to vote. We have another presentation coming. Yes.
For example, you mentioned 7% and then you did it at 20%. So, indirect obviously at 80%. Does it make sense to have another one or two to verify?
You mean when you say 80%, 85%, that's information time, or are you talking about power? Information.
At till what information point time does it?
That's a personal guideline for people. people, it's, don't think in terms of information time. The more information time, the better. The smaller the confidence interval, the better. The further away you are from the boundary, the better. The higher the relative risk, the better. How much higher, how much this, everybody has their own opinion.
Okay.
And you think about, is this convincing enough to people that are in the clinical practice and are looking at elderly people with systolic hypertension? Are they likely to change based on this? But it's a personal appreciation.
Okay.
All right. Who votes to stop the study now, or who votes to continue to study now? Anybody? All right, raise your hand if you want to stop the study and raise it high.
2 points going, 2 Z values going above the value, or 1 Z value go above.
You're voting for where you are right now, which is, yeah, no, you're voting for the fact that you are here now.
Now we near 3.
You are here with a Z near 3.
No.
And you way past the boundary.
In this situation, I vote for stop. To be stopped.
Well, I'm asking, who votes for stopping? Who votes for not stopping? Do you know what the committee did? They continued. Now, I want somebody to tell me, why do you think the committee continued? The sponsor? No?
No, one thing is that as a board statistician, I see that the relative risk did not change much from the previous visit to this visit.
Okay.
Or the stroke. Not much change.
But the Z value changed considerably.
Changed. But as I'm seeing on the whole report, even if you look at this, I could have stopped the first instance itself. You can see the death. It crossed the 2.5, the first Z point. If it is so, it is so bad, adverse. If I project that one, I could have stopped. It was not stopped. We continued. As a result, the death has come very clearly downtrend. That is the most important point for me than the stroke.
So you want to change the primary outcome to death?
Not primary outcome, but
yeah, death is not the primary outcome.
But death is so serious and no suffering.
Because it crossed 2.5, it's on this side of the 2.5. It's doesn't. There is a boundary.
The boundary.
So it's not significant. It's on this side.
But the relative could have been higher side on that.
No, most likely the confidence interval for this is like this. And this is 1.96. So it's not significant.
It's not significant and it's huge. It's not closer to the line.
Number one. Number two is that although the stroke are increasing in the placebo group very visibly, there is no doubt. But in the beginning of the protocol, very clearly the standard protocol given, what is the compensation will be given for those who are participating in the placebo group, number one. Number two, they are under the monitoring. As soon as when they get the stroke, they will be getting admitted to the hospital. It is well known that within 24 hours, a neurologist attending the patient, stroke patient, most likely to get recovered. It is not that life-threatening adverse effect. So such a case they must have, and moreover, 40% that is more in the placebo group, still it is less than the 50%, 50-50 chance. So I feel that as a statistician, 70% gain on the other side. So I feel that yes, that way should be continued.
Okay. So does the study continued? Now I'm asking, before I reveal to you why, anybody wants to guess why they decided to continue?
Almost there. Finish it up.
Almost there is one, but that's not exactly the reason.
The low event rate would not have made a significant difference.
It's not the conditional power.
The event rate, which is so low, may not have made a significant difference to adverse outcomes in that 1 month. And they could have completed the trial without unblinding the.
The number of events is much
So all of these things are what is happening, but that's not why they decided not to stop. The reason they decided not to stop is, I had mentioned to you earlier about closing out a study. If you stop a study in December, you're closing it out in December as opposed to in January. What is happening? Christmas. Everybody's on holiday. Where are you going to get your staff to do the closeout? In India, you may be able to close it. But there, they said, this is not, I mean, why are we going to create chaos in 1 month before and create all these expectations that the study was ended early? And so they did not stop it for that reason. When they eventually study ended, the last day when they published, look at what they got. 3.6. They published it, and they felt so much that they had to justify why they did not stop the study early. And so this paper in controlled clinical trials gives you the arguments by the board members of why they didn't stop early. So these numbers I got from that paper. They didn't create the graph, I created the graph. But Janet Wittes was on that board. She's the most famous DSMB board member together with Dave Demetz and Tom Fleming. But you're free to read this, the paper itself and the rationale and design of the study, but read this paper and you'll get some insights as to how the board thinks and how easy it is to be a board member. All right.